Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit Podcast.
Hello, and welcome to another exciting episode of the Med Edit Podcast. I am your host, Dr. Cari Sorrell, in the studio, as always, with my fabulous co-host, Dr. Jessica Gray.
Hello again to all our TME listeners.
Woo woo! Before we kick off our first Men's Health Takeover, we have an exciting announcement.
So the Med Edit Podcast is officially accredited by the Texas Tech University Health Sciences Center. What does that mean? Well, it means that if you are a medical student, a resident, or a physician listening to the podcast, you can claim CME credit just by listening alone, all for free.
You heard that right. It's CME for free, and all you have to do is listen.
Well, there are just a couple little instructions to follow to claim your credit. Just take a look at our show notes, and you can find out how to claim that CME credit starting with episode 10 and every episode following.
We always knew listening to this podcast would make you smarter, but now we can prove it.
And now on to our show today. Today is our first Men's Health Takeover. Here at the Med Edit, we focus primarily on women's health topics. But many of us have husbands, fathers, brothers, friends who are men, and it can be hard for them to find reliable medical education. So whether you send this episode link to a man in your life, or if you just listen and share this information with them, it will definitely be information that you don't want to miss.
Absolutely. And our guest on the show today is Dr. Timothy Dixon, who will be discussing some of the most common men's health topics. We will discuss testosterone, hair loss, and prostate cancer screening.
We have a lot to unpack today, so let's get started. For our first ever Men's Health Takeover, we are joined today by board-certified internal medicine physician, Dr. Timothy Dixon. Dr. Dixon works for University Medical Center, where he has an outpatient primary care practice, and he works as a hospitalist managing complex patients admitted to the hospital. Dr. Dixon is a graduate of the Texas Tech University Health Sciences Center Internal Medicine Residency. He has a passion for preventative care and obesity management. Dr. Dixon, thank you so much for joining us on the show today.
Thank you. Happy to be here.
Yeah, we were super happy to have you as our first male guest on the show. You know, we feel like you should get a certificate or award for that.
There we go.
You know?
We'll make you one.
We'll make you one.
I'll take a plaque.
Okay,
we'll work on it.
Maybe a participation trophy. No promise.
We'll see how it goes.
See how it goes. We'll see how I do on this first.
All right, so let's start with the topic every man is always very concerned about, testosterone. I feel like the amount of information that's out there, and a lot of it is inaccurate information on TV or pushed on social media about testosterone, is kind of exhausting to keep up with. Whether it's, a former athlete selling a supplement or a fitness influencer using a scare tactic, talking about testosterone is all the rage, no pun intended. So let's get back to the basics. What is testosterone? Why do men have it? And what is the natural course of testosterone as men get older?
Great question. So testosterone is a sex hormone that's produced in what are called your gonads, or your sex organs. So for men, it's the testicles, and for women, it's the ovaries. Your adrenal glands, which are glands that sit on top of your kidneys, also produce a hormone called DHEA that is transformed to testosterone and estrogen. Testosterone is usually much higher in men. It's the main driving force in the development of male genitalia and development of characteristics seen in puberty, such as body hair, sex drive, height, muscle mass. In men, testosterone also tells your body to make new red blood cells to carry oxygen to your organs. It keeps your bones strong and your muscles strong. It also enhances your overall sense of well-being. Now, here's the unfortunate news. Starting at the age of 30, between the ages of 30 and 40, your testosterone naturally declines by about 1% per year.
It's a good statistic. I've never actually, even as a doctor, been able to quantify that. So that's a good statistic. And so that's natural. That's not a bad thing always either. Like, that's a natural course of being a human.
It's just kind of with kidney function and a lot of other things. It's just a natural process as we get older, unfortunately.
So when a guy comes in to see you in the clinic and says, Doc, I'm worried I might have low T, that's the big buzzwords, the low T. How does that discussion or assessment typically go with you and the patient?
Well, the first question is an open-ended one, which I'm essentially saying, fill me in a little bit more. What is exactly causing this concern? Because the majority of time it'll be energy related. They'll say things like, I'm just not as energized as I used to be, or I'm not as focused, or I'm not interested in things that I used to be interested in. That's the most common one, but they'll also usually describe some form of performance issue in the bedroom. That's either going to be erectile dysfunction, low libido, or both. So the first thing that I do, I assess risk factors or clues in the patient's history that can lead to a suspicion of low testosterone. And these include a history of low bone mass, muscle loss, diabetes, HIV, and chronic opioid use. Now, obesity definitely plays a role as well, but also is a risk factor of more common causes of overlapping symptoms, primarily sleep apnea, which affects 15 to 20% of men. But if a patient's diabetic, they're closer to 30% more likely to have hypogonadism, which is the term for the reduction of hormone secretion from the gonads. But if the fatigue is the only symptom, I look for signs of more common causes, such as sleep apnea, low thyroid, and the often forgotten one, depression. If there are other accompanying signs, including muscle loss, erectile dysfunction, especially if they have a risk factor, that's when we'll go ahead and consider testing. But, another thing that I have to explain to them, especially if they've been, quote, diagnosed with low testosterone before, is that in order to really diagnose, you have to have at least 2 readings of low testosterone taken early in the morning. And so that's the initial discussion that I have with them, just so we're on the same page of not only the data, but other things that they need to think about. Because whenever you have something that is high in the media, that's all they think about. It's tunnel vision on that disease. And so part of what I do is I broaden the picture a little bit and explain other things. And sometimes they'll say, my wife does say I snore and stop breathing in the middle of the night. And the conversation kind of takes its own turn.
I think that's great. That is a really good point. And so that's one thing I do in my clinic too, is that when they start having these complaints or concerns even about the testosterone, sometimes we don't even check it because we start talking, well, your uncontrolled diabetes or uncontrolled hypertension are more likely to cause that if we're not having some of those other symptoms you were discussing as just fatigue.
Mm-hmm.
But the social media and the news would definitely have you believe that it is definitely that low T. And if you just replace it, it's going to be better.
Mm-hmm. Absolutely.
I mean, it's kind of been raised in women as well now, right?
Yeah,
it's not even just men that they're kind of advertising it to.
So you see all those doc in the box style clinics popping up all over town advertising testosterone replacement therapies. Are they legit? Are they anything to be worried about? Are there risks to the testosterone use, even if you just came in and just got some?
Well, like many things in medicine, testosterone's a huge market. And where there's supply and demand. Advertisements on social media and TV create a notion that testosterone deficiency is some sort of epidemic, although data suggests that overall only 2% of men have it in the absence of risk factors. Many of these places that pop up, unfortunately, capitalize on this and offer a solution. So which basic marketing is to create some form of anxiety or need, then have somebody else pop up as a savior and provide the solution to make a handsome profit. Now, I'm not saying all of these clinics are illegitimate by any means. I'm just saying that you have to be careful because more times than not, patients that I have that were put on testosterone from certain clinics that were advertising this were never even properly worked up / diagnosed, and statistically were unlikely to have low testosterone. But here is my big problem with this. One of the risks of taking testosterone is worsening of sleep apnea. So if a patient is just fatigued all day and gets testosterone and their underlying disease was actually sleep apnea, you just made the patient worse and you led them to a higher risk of significant cardiovascular and pulmonary disease. There's also a risk of growth of your prostate, infertility, and blood clots.
That's something that was really important to know, is there are risks to using this supplement. It's not as, easy as the I don't know, Shaq on TV. I can't remember if it's him or not, but one of the, former athletes, it's like, oh, just add it into your diet, or here's this little supplement that compounds it or something like that. There are risks to actual true testosterone replacement therapies.
Vitamin T.
So if a man truly, Yes, the low T. If a man truly does meet the criteria for the diagnosis of hypogonadism, that testosterone deficiency, how is it managed and who manages it?
First of all, we need to have baseline labs, make sure that testosterone therapy is safe, which includes labs to check your blood to make sure it's not too thick, which can lead to clots, a baseline prostate cancer number and liver function. If all is good, there are several options to replace testosterone, including topical gel, injections, which are by far the most common that I see, and implants, which you can have heard of, the pellet. So once they are on some form of testosterone, they need to be closely monitored. Liver function usually has to be checked every 3 to 6 months. PSA needs to be checked every 6 to 12 months. Annual cholesterol, the hemoglobin hematocrit, which is what we are checking to make sure your blood is not getting too, quote, thick, gets checked every 6 months for the first year and a half, and then I'll check it annually.
That's a really good point, because that is something that happens often in my clinic. Is they'll come in on it. They haven't seen a doctor in maybe 8 months, a year or something. And they're like, hey, doc, I need to replace this, or I need to go back on it. But they haven't been monitored. They haven't been checked. They haven't had some of these things. We draw their baseline labs, and that hemoglobin hematocrit is sky high. And, I'm trying to talk to them. This is that thick blood you keep talking about that puts, risk factors for blood clots and stuff. And then trying to take a guy off their testosterone, man, that's a hard thing to do.
Ooh,
for sure.
That's rough. And especially when they've been on it for 10, 20 years. And it's tough. It's definitely a tough conversation. It's much tougher than somebody who hasn't been on it. And now I can kind of have a clean slate and have that conversation. And so that's when things get a little muddy.
Yeah, absolutely. And, it's funny because we always talk about the things that we kind of learn once we start practicing, and I feel like, obviously the background, physiology of this we were taught, but seeing patients come in on testosterone and realizing the issues, like, honestly, I had to educate myself about when the pellets and stuff started coming out. And I started seeing a lot of patients in my clinic with bowel problems. And I'm sitting here trying to figure out like what's changed. And really, for a lot of them, the only thing I could find is that they'd had the pellets implanted, and all of a sudden there's like a diarrhea problem or a constipation problem. And I had to educate myself on why that may be the case. Because again, you haven't seen a lot of that replacement until it became, everybody, it seemed like everybody was talking about it. And that's kind of always the issue, like you mentioned with the liver function test, as well as with the implants that I always had an issue with, because they'll send them to me and I'd be like, well, I can't do anything about it right now. Like it's there. I have to wait till it goes away. It's not like it's the strip or a gel or injection where we, the half-life is, fairly quick or, comparison. And it's kind of tough because they'd want you to work that up or manage it. And you're like, it's in there. I can't do anything about it right now.
We can't take those pellets out of your booty. They do not come out of the skin. I have the same problem with my women who get them, and they have too high of testosterone, and their hemoglobin hematocrit are high, and they're having acne on their face with like really bad acne and scarring. And then they're saying, how do I get it out? And there are some meds that could maybe help, to help lower it. But truly, you just got to let time, you got to let time handle that, which is definitely hard.
Right. Which reemphasizes the importance of properly getting worked up and making sure it's important, because the risk versus benefits, like anything else, it's just not a good idea to just do this without knowing for those reasons.
Absolutely. And I know we kind of already mentioned this as kind of the elephant in the room, but we talked about erectile dysfunction and libido. How does testosterone play a role in that?
Well, first we need to take a step back and kind of differentiate the kind of erectile dysfunction. And that's when I talk to them and they're saying, I'm having erectile dysfunction. I think my testosterone's low. We first look at underlying risk factors for specifically erectile dysfunction, the physiologic form, which is, vascular disease and diabetes that can cause this. But one question that I do ask my men that can sometimes be a little awkward, but it is what it is can you achieve an erection by yourself? And also, do you have an erection in the morning? And so if they don't have a problem achieving erection on their own and it's only an intercourse, that's more of a psychogenic erectile dysfunction type that could be helped by some CBT generally, but it doesn't show me that you have low testosterone. But in general, so whenever we have diagnosed, okay, no, in any circumstance, they cannot achieve an erection, and they also have low testosterone. The benefit is testosterone is the primary sex male sex organ, and it helps, the development of the testes, but also helps the libido. Increased libido naturally is going to help increase your ability to maintain an erection, but it also, like we were talking about before, enhances blood flow, helps create new red blood cells delivery to the tissues. It also helps with the energy levels. And so when your energy is low and you're just not feeling well, that also in itself affects libido. So it's kind of multifactorial, and it takes care of all the other underlying things that then can help your performance and make you and your partner happy.
Absolutely. I'm trying to hold back. I'm debating whether I throw out there for our listeners one of those fun tidbits you learn in medical school, because I definitely have counseled patients about this. You'll ask them, do you have an erection when you wake up in the morning? And they say, I don't know. I have no idea. So Dr. Dixon remembers this from we talk about medical school. There's a little trick that they can do at home, that they can take a piece of paper, cut it into a strip, like a long, like kind of like ruler-like strip, cut it down, and then put a little tape around it, and put it around the penis before you go to sleep.
Mm-hmm.
And if the paper is broken in the morning, it was broken by some force slightly, then you have achieved an erection overnight.
Mm-hmm.
Is that the best way to describe that, PC, on a podcast?
I mean, it's medicine, it's science. So it's just one of those people are really uncomfortable talking about. But the problem is there is a major psychologic component that can be damaging, not only to an individual, but to a relationship. And so although it's something that is taboo to talk about, and men primarily are nervous to talk about, not addressing and treating can lead to really serious consequences overall. And so it is something that I think we need to make the patient feel more open to talk about this. This is something that is your body, and it is your relationship, and it is your self-confidence. It's your level of self-confidence that plays a role in all of these things.
And if we're blaming it on low T and that's not truly the issue, then we're injecting you with a potentially harmful hormone that's not even going to fix the problem,
Mm-hmm.
right? So, we could give you low T all day long, but if there's a psychogenic factor that's not being addressed, or even diabetes or some other underlying condition, then we're just doing more harm than good. And isn't that our whole point of being doctors, is do no harm in the first place?
Exactly. Especially if the cause is severe vascular disease and you don't have low testosterone. It's a rabbit hole that we just go down quite a bit. And sometimes the conversation is not just one, but multiple over our follow-ups.
Mm-hmm. Well, and that's why we're not afraid to talk about those things on the podcast here. Try to make it something that we can talk about those taboo subjects. But switching gears, let's discuss one of our very other common topics that men often have questions about.
Ladies, have you noticed your man's hair thinning? Maybe they're developing a bald spot on top of their head, or maybe that hairline is receding a little bit. That's another pretty sensitive topic for a guy. Dr. Dixon, how do we help the men in our lives when it comes to hair thinning?
Well, so the most common thing that we're talking about is male pattern hair loss, MPHL. It's the most common type in males. So there was a study in the U.S. that I think it had 266 healthy men, and 48% of them aged 18 to 49 were shown to have this. Hair loss for this typically begins in the temporal scalp, this mid-frontal area, and then on the vertex. It's a continuous process, but it also has areas of plateau where you will slowly notice some hair loss, and then there will be a period of time where you do not have any, and then you'll have more hair loss. So it's in intervals. So whenever I first see this, I have to keep the differential broad because there are other causes of hair loss. But if it is male pattern hair loss, we still need to do labs because there are some underlying things that can cause this. Primarily the thyroids. We want to check your thyroid levels, and we want to check your iron levels, make sure you're not iron deficient. There's other things that sometimes people don't think of, is whenever you're having patchy hair loss without visible scarring, we need to consider things like syphilis, because these are also things that can cause that. So the first thing I'll do is have that history, and then we'll go into the physical exam to see different patterns. So I'll first look at that pattern, that general pattern of hair loss, and if it fits, and there's nothing else that could explain another disease process, we can go from there. But there are other things that can cause the hair loss, like cicatricial scarring or alopecia, where you'll see pain, you'll see itching, have inflammation, these papules or pustules. Those are things that are more concerning. It's not as much in line with male pattern hair loss. And then there's other things called so trichotillomania is also one. So that's a psychiatric disorder. You have hair pulling, so there's going to be bizarre hair patches around the head, and they're going to be pulled in different lengths. So that's just kind of the general approach I take to kind of help with that diagnosis and assessment.
Interesting. And once you've kind of ruled out those other things that we can absolutely treat and intervene on, what treatment options for the male pattern baldness do you usually recommend or discuss with your patients?
My number one recommendation is topical minoxidil or Rogaine. And you can actually get this over the counter as well. But, randomized clinical trials support efficacy, safety, and tolerability of this. The regimen there's a twice daily application. It's 1 milliliter that you can put on the area of concern and you rub in. But there's also the foam version that sometimes that is just once a day. The issue is the consistency that's required to see these results. You have to have at least 6 months of consistent usage in order to achieve this. And sometimes that's difficult. And a lot of people, and sometimes we get into this expectation adjustment discussion where they'll do it a couple times a week for a month and say it didn't work. We don't know if it didn't work because we didn't give it a real trial. So it has to be consistent at least 6 months. So that's going to be my initial approach, is the topical solution. If that ends up not working, so we can also add what's called finasteride, which is oral medication. So the standard dosing is 1 milligram per day. Treatment should continue for at least 6 months as well to assess the efficacy. For some patients, it can take up to 12 months. The issue is because it's oral, it's systemic, it can have negative side effects, such as side effects of sexual dysfunction, erectile dysfunction, decreased libido, ejaculatory dysfunction. And so, if that becomes an issue when you discontinue it, those symptoms usually, resolve on their own. It's not permanent. There are other therapies that I see that are less common. Low-level laser light therapy, which involves use of specialized comb, helmet, or other device that deliver red or infrared light to the scalp. The mechanism of action is not fully understood, but may involve stimulation of hair growth. Further studies really need to be undergone before we can better understand this. And hair transplantation, which is not cheap, but it is an option, and platelet-rich plasma. But once we get to that point, that's when we have to really weigh our other options.
Interesting. Yeah,
definitely. I think the biggest thing is that setting that expectation, right? That you've got to be sticking with it for 6 months minimum to be able to say it didn't work. And the other thing is that those online companies that will send you the vitamins and the pills in like a little baggie, and they'll say, here, take these. A lot of them do include finasteride in it to help with that hair growth. And I don't feel like the patient always is aware that there's potential negative side effects, not for everybody, but just if you're all of a sudden having those side effects and you're taking the finasteride, you may think you have two things going on. You may think I'm having hair loss and erectile dysfunction. Well, one could actually just be a side effect of the other. And I think that's something that's really good to look at and talk to your doctor about. You maybe not want to let them know you're getting your hair growth medicine online and, you think it's just a supplement. Well, it's not a supplement. It's a prescription, and there can be potential side effects.
Exactly.
Are there any red flag symptoms men should be aware of that indicate there's a bigger problem than just that male pattern hair loss?
Absolutely. So alopecia areata, it's an immune-mediated form of non-scarring hair loss. It most often manifests as sudden hair loss in kind of a circular, discrete area, but can also have larger patches. The differentiating factor in the history of this is, like I was talking about before with male pattern hair loss, it's going to be slow. It's going to kind of have plateaus. Whereas this other one, it is more rapid. It is a kind of sudden, rapid loss of hair. And at that point, that's when we need to consider a referral to dermatology for scalp biopsy.
That's really good to know. That's a good way to put it. Yeah, that just that sudden loss of hair is different than what we're normally seeing as we age just a little bit.
Yeah, and I think the great take home point there is that even though this is very common, so a lot of men experience it, it's really important to talk to your doctor about it because it could be something else going on that needs to be evaluated, or there may be other treatment options you're not aware of.
Yep.
Absolutely.
Right.
And then kind of delved on it a little bit, but the cicatricial, which is the scarring alopecia as well. That's when we have to make sure that there is not signs of inflammations, redness, itching, pustules, anything like that. And then obviously the psychiatric disorder of trichotillomania. I just
Don't
kind
know.
of got a
One
little
way to say
tongue
it.
tied.
Yeah. Tongue twister.
Trichotillomania, which is just
Great
this
job.
impulsive pulling of hair that you see on there. So those are the three main things that we look at that will require a different approach to management than your typical minoxidil or finasteride.
Awesome. Well, great summary for hair thinning, which you mentioned is a very sensitive topic for a lot of men and women. So I'm glad that we were able to cover that. For our final men's health focus of the day, we're going to talk about the prostate, and specifically prostate cancer. Prostate cancer is among the most common cancers in males worldwide, with an estimated 1.6 million cases and 300,000 deaths annually in the United States. 11% of males are diagnosed with prostate cancer over their lifetime, with the incidence generally rising with age. The good news is that overall 5-year survival rate is over 98%, which is wonderful because we can't say that a lot about a lot of cancers. Dr. Dixon, what symptoms does someone present with when they have prostate cancer?
Most prostate cancers are diagnosed in the localized stage, meaning they haven't necessarily metastasized or moved to other parts of the body and are typically asymptomatic. Less commonly, prostate cancer might present with nonspecific symptoms of the lower urinary tract, like blood in the urine, which we call hematuria, or blood in the semen, which we call hematospermia. These symptoms were commonly due to non-cancerous conditions, in particular symptoms such as frequency, urgency, nocturia, which is getting up in the night to go urinate, or hesitancy. Those are more related to a benign process called BPH, benign prostatic hyperplasia, rather than to prostate cancer. Among 6% of patients whose prostate cancer is metastasized at the time of diagnosis, bone pain may be the presenting symptom. So bone is the predominant site of dissemination for prostate cancer, and pain is the most common manifestation of bone metastasis. So you have a male with risk factors. They have the lower urinary tract infections, but they're having very bad lower back pain, and there's that point tenderness right over the spine. They're having night sweats, all these other things that make you a little concerned. That's something that we need to evaluate.
So, what are the most up-to-date recommendations on how to screen for prostate cancer? Over the last several years, this recommendation has changed, and it's important for both doctors and patients to be aware of current guidelines and that this has changed.
Well, the first is we have to have a discussion. It usually doesn't just go, you need to be screened for prostate cancer. Okay. There's a risk and benefit discussion that has to be made, because there are the risks of false positive PSAs that lead to extensive stress and diagnostic testing. So the first thing we have to do is weigh the risk versus the benefits, based on the patient's risk factor. So for testing, it is recommended to start at age 55 per the AUA. For patients between the ages of 40 to 54, screening is recommended in patients with risk factors of prostate cancer, such as a first-degree relative with prostate cancer, metastatic or lethal cancers such as male and female breast cancer, ovarian and pancreatic cancer that spans multiple generations or affects first generation. African American race is also a risk factor that warrants earlier screening between the ages of 40 and 54. The American Urologic Association recommends against screening patients under 40 or over 70, or any man with 10 to 15 years life expectancy or less. However, they do say if you're 70 plus in excellent health condition, screening might still be a benefit. So PSA is the most commonly used and most valuable test for early detection of prostate cancer. The value of prostate cancer, I have to repeat that. The value. Prostate cancer is not valuable. The likelihood of prostate cancer increases with more elevated PSA values. PSA testing in a man without a history of prostate cancer is most often done for screening purposes, but testing is sometimes performed as part of an evaluation of symptoms. This is what's important. An elevated PSA can occur in a number of benign conditions, and a PSA result in the normal range does not rule out the possibility of prostate cancer. There are a large amount of population that have a normal PSA that still do have prostate cancer, and there are a lot of people that have a high PSA that don't have prostate cancer.
So say they come to see you in clinic and their PSA is elevated on that screening. What usually kind of follow-up do you do on that lab?
Well, before I hit the panic button and refer to urology, the first thing I do is repeat the PSA in about a few weeks just to confirm it's elevated. There are modifiable factors that can temporarily raise the PSA, which is something like long distance bicycle riding, ejaculating within 48 hours of the test. So these factors do need to be addressed prior to repeating the PSA.
That's a really good point. What about the dreaded digital rectal exam, the one that we commonly associate, with men getting prostate screening? A lot of them always think that, I have to actually have the physical exam part.
Yes.
What happens with that?
I get this question a lot, especially in older men. They come in to establish care for their annual and say, I'm here for my annual rectal exam. And what I tell them is, so digital rectal exam has very minimal diagnostic value in detecting prostate cancer. It might detect nodules, but the thing is with a digital rectal exam, it can only detect tumors in the posterior and lateral aspects of the prostate gland. These are the portions of the prostate that are palpable via the rectum. So a digital rectal exam is generally not recommended as a routine screening test for evaluation of the prostate or rectal area in the absence of symptoms.
And I like that you said that because surprisingly, as a gastroenterologist, I actually get asked this a lot. I get asked by people a lot to check their prostate while I'm doing the procedure. And I kind of have to have the same discussion with them that it doesn't necessarily exclude things. And there needs to be kind of a more thorough history and workup if that's really what we're screening for.
Exactly.
I often get a lot of times too, my patients are confused with the difference between the colon and the prostate.
Yes.
Just very basically. And so they say, my women, I don't need a colonoscopy. I don't have that. Well, you do. All of us have colons. Prostates and colons are very different, and they're completely separate organs, completely separate cancers, and detecting these cancers are completely different.
Yes, and I have had patients that I have recommended a colonoscopy, and they said, well, I had my PSA checked last year, and it was normal, and so wouldn't that detect colon cancer? And I get this, quite a bit, and so we definitely have to have that discussion because that is a common thing that people need a little bit of clarification on.
Absolutely. And that's why we're here. We're here to clarify those questions for people.
So who does need to be referred to the urologist?
So if there's a clinical suspicion for prostate cancer, either because the PSA is very high, repeated levels are high, or if you have an abnormal digital rectal exam, you need to go ahead and refer them for urologic evaluation. There's also a genetic component. So men with a known genetic predisposition of developing prostate cancer, such as those with this pathogenic variant in a cancer predisposing gene, such as, BRCA, we'd hear of BRCA mutations in breast cancer, but, BRCA1, BRCA2. So these patients with genetic predispositions should be referred to urology as well for recommendations about screening.
Awesome. Well, that is all such fantastic information. And these are all really important topics if you're a man listening to this for you, and if you're a woman for the men in your life.
That is a wrap for our Men's Health Takeover. Thank you, Dr. Dixon, so much for joining us on the show today. Don't forget to check out those show notes in order to claim your CME credit if you are in the medical field.
And thank you all for listening. Please like, subscribe, and share this episode. Let us know what other topics you're interested in through our Instagram, and stay tuned for the next episode.